Podcast is now starting. All attendees are in listen-only mode.
Good afternoon. Thank you for joining the Weekend Educational Series. Today, Dr. Hilary Petska will discuss hair drug testing. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log into your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
All right, well, good afternoon, everybody. As she said, my name is Hilary Petska. I am a physician at Children's Wisconsin and specifically a child abuse pediatrician. I've actually been really excited to do this talk for a while. I've been wanting to kind of do a more complete literature review on hair testing, and so this was a really nice opportunity to do that. I do not have any financial disclosures, but I do want to say, because this is the first time that this lecture is being given for WeCan, any feedback that anyone has regarding kind of what you would like to see in the future or just feedback in general would be really appreciated. I will obviously do my best to answer any questions along the way, but if I don't know the answer, I'll make sure to include that information in future talks. So today you're going to learn more than you probably ever wanted to know about hair and hair testing, but there are three key points that I'd like to focus on. First, there's no national consensus on which children should be tested for which drugs or how, whether that's urine, blood, or hair. This results in significant variation in practice among providers. Second, no test is perfect. Each has its own limitations. And finally, we have a responsibility to understand what these limitations are for each test to prevent misinterpretation and misuse of results. So we're going to start by discussing some basic terminology and concepts. The National Alliance for Drug-Endangered Children defines drug-endangered children as children who are at risk of suffering physical or emotional harm as a result of drug use, possession, manufacturing, cultivation, or distribution. This includes children whose caretaker's substance misuse interferes with their ability to parent and provide a safe and nurturing environment. One of the biggest challenges really is identifying children at risk, and so that's what I want to focus on today. As a point of interest, this issue is gaining widespread attention in the media and in pop culture. For example, National DEC actually recently partnered with Sesame Street, who in 2019 introduced a character, Carly, whose mother is struggling with addiction. So how bad is it? Substance abuse in the United States is a public health crisis. The opioid epidemic claims more than 130 lives per day, and as a result, our national life expectancy has actually decreased. Marijuana is becoming increasingly available to children and others as more and more states legalize it. Methamphetamine use in Wisconsin has increased 462% between 2010 and 2017. And in 2018, Wisconsin was ranked as the worst state in the country for excessive drinking. What those statistics don't capture is how this is affecting children. 1 in 8 children in the United States lives in a household with a parent with alcohol and other drug abuse issues. And in 2016, approximately half of all human drug exposures reported to U.S. poison centers involved children less than 6 years of age. So we're seeing drug-endangered children regularly, whether or not we know it. Over the last few decades, we've learned that adverse childhood experiences, or ACEs, things like child abuse, neglect, and household dysfunction, such as having a caregiver with a substance abuse disorder, lead to increased risk of short and long-term negative health consequences. Like an oil stain, ACEs seep into every part of a person's life, affecting their health and well-being. They're actually associated with most of the leading causes of death in the United States. So as an example, preventing ACEs could prevent 21 million cases of depression, 2.5 million cases of obesity, and 1.9 million cases of heart disease. And we know that people with 6 or more ACEs in general have a 20-year decrease in life expectancy. Unfortunately, for children with a parent with a substance abuse disorder, these ACEs or these risks accumulate very quickly. So you can see how a parent who has a substance use disorder may be using because of a mental health, an undiagnosed or untreated mental health disorder, which is another ACE. People who are using drugs or alcohol will have an increased risk of interpersonal violence, both with others, so like domestic violence, or towards children. They are less patient, have increased risk of abuse or neglect, more ACEs. And so you can see quickly how you go from caregiver substance abuse to an ACE level of 6 or higher. So how do we identify at-risk children before they develop these negative health consequences? Drug testing is obviously one of the ways we do this. I tend to view drug testing like other types of injury surveillance, such as skeletal surveys, that we perform to obtain additional information or history about a child, especially in pre or early verbal children who cannot provide it themselves. A lot of times, caregivers also will not offer that information. Detection of a drug-endangered child represents an opportunity to improve their life course trajectory. Unfortunately, as I mentioned, there are no state or federal protocols that tell us which children to test for drug exposure, what specimens to use, so urine, blood, or hair, for example, and which specific drugs to test for. As a result, there's significant variation in testing. In Wisconsin, for example, the substrate used depends on current best evidence, local environment, like proximity to medical care, multidisciplinary relationships, and clinical judgment. When we think about an ideal screening test, there are a number of characteristics that should be considered. First, the results of the test have to be available relatively quickly. To be useful in a clinical setting, a test has to be able to provide results that could be used in the care and management of a patient before they're discharged. So if I need to know whether or not to administer Narcan to counteract an opioid exposure, the test result won't be very useful to me if it's not available for several days. Second, the test has to be specific. In other words, no or very few false positives. There are significant consequences if a child is treated for an exposure that they weren't actually exposed to, or if CPS or law enforcement are called prematurely. If I'm testing for a drug, I want to know that a positive result means that they were exposed to that drug, not another drug with a similar structure that made it look like they were exposed. 3, a test should be highly sensitive. So for example, most ED urine drug tests are not terribly useful in children. They were initially designed for the workplace, where employers are trying to identify heavy, frequent drug use or problem drug use in potential employees. In a child, however, any exposure is unexpected, and so we'd want to be able to detect any level present in their system. The test also has to be reliable. So no matter which lab I send my sample to, I want to know that I'm going to get the same result. In other words, there has to be a standard way of performing the test and reporting the results. A test that is not easy to perform has a higher rate of errors and variability in results, as well as reduced availability, as not all labs will have the ability to perform the test. And it should be relatively inexpensive. It's difficult to justify routinely performing an expensive test without an obvious benefit. In the case of pediatric drug testing, the screen should also use an easily available substrate, so something like hair or urine, include a broad range of drugs, and have reflexive confirmation of any positive result. Finally, it's difficult to justify performing a test if the result cannot be interpreted. There are a number of biologic matrices or substances that are commonly used for drug testing, including urine, blood, breath, saliva, sweat, hair, and meconium, or newborn feces. Each has its advantages and disadvantages, but no commercially available drug test has all these criteria met. So a variety of tests exist and are often used together to detect and confirm an exposure. So let's talk about hair. I want to start by reviewing a little about anatomy because I think it's important to understand how drugs are incorporated into hair. So hair is primarily made of keratin, which is the same substance in our fingernails, and the only living part of hair is the hair follicle, which is supplied by a blood vessel called a capillary. You can see right there. You can also see that the hair follicle is closely connected with sweat, which is tied right around there, as well as sebaceous or oil glands, which is kind of along the hair follicle as well. So there are 3 major routes in which drugs are thought to be incorporated into hair. First, deposition of drugs into the hair shaft from systemic exposure. So in other words, a person ingests or smokes a drug, it gets into their blood, and it is then deposited in hair via the blood supply to each hair follicle. Second, drugs are transferred via sebum or sweat. So someone is out jogging and their hair gets coated with sweat and anything their sweat may contain. And third, environmental exposure. So someone is in a room where someone else is smoking and the smoke deposits on their hair. It's important to note, though, that for the last two routes, drugs are not just deposited on the hair, but are also incorporated into the hair itself. This is going to become important as we continue talking. Looking a little more closely, each hair consists of three main layers: the cuticle, which is the outer layer there, the cortex, which is the majority of the hair strand, and the medulla, which may or may not be present in any given hair. The cortex determines whether the hair will be curly or straight and contains melanin, which is a pigment that determines the color of the hair. It's also the layer of hair in which drugs accumulate. There are also three main types of hair: vellus, which is thin and non-pigmented, so that's the kind of hair that is found on areas of our bodies like the forehead; intermediate hair, which is the hair found on our arms and legs; and terminal hair, which is thicker and more pigmented and found on the scalp, in the underarms, pubic area, and in males in the beard. Terminal hair is the preferred type for hair testing. Hair goes through cycles of growth every about 5 to 7 years, involving three phases: anagen, catagen, and telogen. Anagen is the stage of active growth, and it's the stage in which hair spends the majority of its time. Grows in that stage about 0.5 to 1 centimeters per month. That's kind of the standard growth rate that we see. This is the stage in which drugs are thought to be incorporated into hair. Catagen is a transition stage, and in telogen, the hair does not grow at all and is easily removed from the follicle. So when you're brushing your hair, those hairs are the ones that are coming off in your brush really easily. At any given time, of the approximately 1 million hair follicles on the head, 85% are in anagen phase and 15% in catagen or telogen. Beard, underarm, and pubic hair grows more slowly than scalp hair, but growth rate in general depends on things like gender, age, race, and location. So hair testing first surfaced in the literature in 1858 after a case report was published about traces of arsenic that were found in the hair of an exhumed body. Historically, arsenic was often implicated in poisoning, but was really difficult to prove. Hair testing resurfaced in 1977 when researchers out of LA detected morphine in the hair of morphine users, after which they published their results in 1979. In 1987, NIDA, or the National Institute on Drug Abuse, began to consider hair as a test matrix for the federal drug testing program, but at that time ultimately concluded that there was insufficient evidence to use it in the workplace. In 1995, the Society of Hair Testing was formed with the goals of promoting research in hair testing technologies and encouragement of scientific exchange among members. In 1998, SAMHSA began to consider using hair testing regularly, but subsequent testing showed major inconsistencies across labs, which raised scientific, legal, and public policy concerns. As a result, in 2009, the FBI suspended hair testing in non-criminal cases. Fast forward 25 years, and methods have improved significantly, as has lab performance. So criteria for what is considered positive has also changed. Today, hair testing is primarily used to screen for drug use in potential employees, but also in court cases, including drug-facilitated crimes like sexual assaults, drug rehab programs when testing for abstinence, athletic programs to test for doping, and reinstating driver's license after a DUI. It's even used in the food industry to detect steroid administration in meat production animals. Obviously, for the purpose of this talk, we're going to focus on the use of hair testing in children. Over the last few decades, hair testing has increasingly been used to identify drug-endangered children and in child custody cases. This includes testing of newborns with sampling at or shortly after birth to detect in utero exposure, and testing of children to detect passive exposure in the home, accidental ingestion, and or deliberate administration of a drug. The reason for this increase in the use of hair testing is obvious. Blood can detect substances for about 12 hours after exposure, urine about 3 days. But drug-endangered children are often not immediately identified after an exposure and may not live anywhere near a medical facility where testing is available. With a window of detection of 90+ days, hair can detect an exposure that occurred in the past, long after the substance is no longer detectable in blood or urine. Overall, hair testing is more likely to detect frequent or heavy exposures, but can also detect a single exposure. Sample collection is easy, unlike blood, which requires trained medical personnel, and can be directly observed, unlike urine, which can't be observed without raising privacy concerns. There is also decreased risk of adulteration. There are all kinds of products on the market and remedies on the internet to beat urine drug tests, but cosmetic treatments that affect detection in hair, such as bleaching or dyeing, are usually visible, and many hair testing companies recommend that cosmetically treated hair not actually be collected. That said, if you do a Google search for beat hair drug test, you get over 4 million hits, so it's definitely out there. Finally, it's easily stored and transported without degradation of the sample. Whereas urine and blood must be stored frozen, hair can be stored at room temperature. There are many examples of this testing modality compared to urine in the child maltreatment literature, mostly out of Iowa. In 2009, Dr. Hayek from the University of Iowa published a study of children up to 16 years of age admitted to the Children's Hospital burn unit with abusive burns. 30% of those patients also tested positive for illicit drugs. Hair testing was their primary testing modality. In 2011, Dr. Oral, also from University of Iowa, published a study in which children evaluated for abuse and neglect were also tested for illicit drugs, 15% of which were positive. In a 2015 study by Stauffer, which is shown here, hair testing in cases of suspected child abuse or neglect was routinely performed. Urine drug screening was also performed in about 75% of the cases. As you can see, hair testing results led to a change in clinical outcome in 71 of the cases compared to no changes due to urine testing results alone. Although the urine testing that was used in this study was a standard ER drug screen, which has a number of limitations itself, the results are compelling. So how is it done? In general, approximately 60 to 120 strands of hair are collected, which is about the width of a pencil. It's recommended that this is collected from the vertex posterior or back of the head because this area of the scalp has the least variable growth rate, more steady rate of hair in growth phase or anagen phase, and it's less influenced by age and gender-related factors. The hair should be cut as close to the scalp as possible and the orientation should be preserved. In other words, the side that is closest to the scalp should be labeled as such. So once the lab receives the sample, there are a number of steps that are undertaken, although the exact methodology and chemicals used vary between labs. The first step is decontamination or washing. During this step, the hair is washed in order to try to reduce external contamination, so things like hair care products, sebum, sweat, and dust. The second step is preparation. The washed hair is cut into shorter segments and then pulverized or ground. Hair is then incubated in acid, sodium hydroxide, methanol, buffer, or water solutions. After extraction, in which the hair is dissolved, so that kind of solves the problem of doing an analysis on a solid rather than a liquid, the sample is analyzed using immunoassay screening and or gas or liquid chromatography with mass spectrometry. Okay, so that was a lot of kind of basics. Any questions at this point?
No questions.
All right, so either that was crystal clear or we've lost everybody. All right, so moving on. I want to do for the rest of our time today is really talk about the considerations when we're interpreting hair drug testing. These tests are really marketed to give the impression that interpretation is straightforward, when in reality a number of factors, including the circumstances of the case, have to be taken into account. Although there are a lot of advantages of hair testing, there are also a number of limitations that make interpretation challenging. So first of all, hair is one of the most variable biologic matrices. We talked about some of those variables earlier, but we'll talk about more in a second. In addition, unlike urine, hair is exposed to the external environment, which can lead to contamination. Interpretation is further complicated when we look at hair drug testing in children. There are many differences between adult and child hair, which affect interpretation of results. So children's hair is finer and more porous, so the risk of contamination by sweat and smoke in the environment is higher than in adults. While about 10 to 25% of the adult population does not have enough head hair to collect, children, especially babies, often have even less hair overall. And the growth phase ratios and growth rates we talked about earlier are variable. I should mention that we don't just have to use head hair. We can use body hair, but a lot of the 1 centimeter per month varies when you start using other parts of the body's hair. For the first 3 to 4 months after birth, then, hair is all growing at different rates to prevent baldness in babies. And so it's not really until 12 months of age that the growth rate begins to approach that estimated 1 centimeter per month rate. Positive hair test in a newborn typically indicates in utero drug exposure during the 3rd trimester, but drugs can be detected from in utero exposure up to 1 year. So that really kind of complicates any hair testing that you're doing within that first year. Breastfeeding may also result in a positive hair test, not only from exposure to breast milk, but also the sweat and sebum of their mother, who would be holding them. Children also have a higher respiratory rate than adults, so will theoretically be exposed to more drug than an adult over the same amount of time. There's also an increased risk of environmental exposure, as children tend to spend more time indoors. Young children are also more likely to be exposed to the sweat and sebum of caregivers than older children because they're being held and carried around. Developmentally, young children are more likely to be crawling around on floors that may be contaminated with drugs and engaging in hand-to-mouth behaviors, such as putting contaminated objects into their mouth. Further complicating matters, there's a lack of published data on drug incorporation into hair or hair concentrations in children. In other words, what's true for adults is not necessarily true for children. The pharmacokinetics and the toxicity of substances vary significantly between adults and children. So the dose response curves and the time from ingestion or inhalation to appearance in hair are really not well defined. So we really can't determine how much a child was exposed to or how often. Hair is essentially a reservoir matrix, and there are too many different factors involved to be able to look back and determine timing and dosage or frequency. One of the biggest scientific questions remaining regarding hair testing is whether it can be used to differentiate systemic exposure from inhalation or ingestion versus environmental exposure from dust, smoke, contaminated surfaces transmitted by food or fingers, or sweat and sebum of a caregiver. Well, the short answer is no, we can't tell the difference. Let's talk about this a little more in depth. There are 3 main methods which have been tried to kind of help differentiate this. The first is washing. So if you wash the hair and there's drug in the wash, but not the hair itself, it's assumed that the child was exposed in the environment only. It just got on their hair. Conversely, if there's no drug in the wash, but there is in the hair, the child was exposed to it systemically or ingested the drug. It was not just an environmental exposure. The problem with this, as we've learned, is that drugs can be incorporated into the hair itself just from environmental exposure. In other words, if it's on the hair, it can end up in the hair. In one study demonstrating this, drug-free volunteers who applied heroin and acetylcholine to their hands and then hair tested positive despite standard washing procedures and consistently negative urine results. The second method is the use of cutoffs. In 2012, the Society of Hair Testing established cutoff levels that they had deemed high enough that it must indicate systemic exposure rather than environmental. As we discussed earlier, however, children's hair is different than adults. It's finer, more porous, etc., so the concentration of drug that ends up in their hair is not necessarily comparable. In addition, these levels are based on anecdote, not evidence. Basically, a level was picked that would limit the number of false positives without missing too many true positives. Finally, cutoff levels are unreliable because external contamination can occur at any concentration. In other words, a small amount could still represent an intentional administration, and a large amount could still represent an environmental exposure. Moreover, the concentration in hair is not always a measure of the degree of danger or risk to the child. A child with lower hair values may be more endangered than another with higher values. In a 2015 study by Wang and Drummer, 52 publications on hair concentrations of drugs in children were reviewed to try to determine whether hair concentration could be used to differentiate active exposure, so things like ingestion or inhalation of a drug, versus passive exposure, in utero exposure, or being in the same room as someone using. What they found was that cocaine, codeine, 6-am, and morphine showed higher concentrations in utero exposure than passive exposure, but there was significant overlap. There was no significant difference for methadone between active and passive exposure. So ultimately, cutoff values that were proposed by the Society of Hair Testing could not differentiate a positive result due to active versus passive exposure in children. This was supported by a study by Smith that found that concentrations in toddler hair were nearly the same as the concentration in the smokers themselves. Finally, many companies test for parent drugs versus metabolites based on the assumption that an environmental exposure should only result in a positive for the parent drug. In other words, if the parent drug, such as cocaine, is present, it must be an environmental exposure because you would expect somebody with a systemic exposure to have formed metabolites. If a metabolite of cocaine, such as benzoylecgonine, is present, it must have been an ingestion because metabolites were formed. The problem with this is twofold. First, as we talked about, children are often in contact with caregivers, being held, sharing bedding, etc., which can lead to transfer of a drug via sweat or sebum. The sweat or sebum of a drug user is going to contain metabolites. Second, so can street drugs. So for example, hair testing companies look for metabolites of cocaine like benzoylecgonine, norcocaine, and cocaethylene as evidence of systemic exposure. However, recent studies have shown that street cocaine is typically not pure. It can contain any of these metabolites. So if a child is positive for these metabolites, they may have ingested or inhaled the drug, or they may have been environmentally exposed to a street drug or a using caregiver. In the study I mentioned a few minutes ago, in which drug-free volunteers applied heroin and acetylcholine to their hands and then hair, several were positive for 6-MAM, which is a heroin metabolite, meaning that chemical conversion can occur without active drug use. Drug companies have tried to remedy this by picking a common metabolite that is not a separately marketed drug, a manufacturing impurity, a chemical decomposition product, or the product of an in vitro chemical reaction on the hair, but they've not always been successful in finding one. There's also significant debate about whether or not differentiating systemic versus environmental exposure matters. Some argue that showing a systemic exposure represents a more realistic assessment of toxic health risk to a child. In other words, a systemic exposure is a more tangible risk than an environmental exposure. There was actual risk of harm to the child because it was in the child's body, not just their environment. Others argue that it does not matter because concern exists regardless of if their exposure was systemic or environmental. Drug use in a child's environment is an adverse childhood experience, and testing is really only being used to identify children and families in need of services, not personal usage. And a lot of times it's possible a positive test represents both systemic and environmental exposure. For example, in utero, a baby is exposed environmentally via amniotic fluid, but also systemically when they then swallow the amniotic fluid. Or a child living with a parent who smokes, there's likely going to be smoke on their hair as well as some inhaled. However, I think we have to be very cautious about the second bullet point. It's an assumption to say that a child's positive hair test was because of exposure in their home environment, even in a child found living in a meth lab. Likely maybe, but still an assumption. The hair could be positive because the child sleeps in the same bed as a user, or because the child is carried by a caregiver who uses. Meth users also tend to hang out with other meth users, so the hair could be positive from another meth environment. Or if the kiddo is less than a year old, the exposure may have been an in utero exposure and the caregiver may not even be using anymore. Regardless, the meth lab in their home is much better evidence of risk to the child than the positive hair test. Another way in which hair testing can be misinterpreted is via segmental hair analysis. The idea behind this is that since we know the average rate of hair growth, we should be able to tell when somebody was exposed to a drug. For example, if the hair 3 centimeters from the scalp is positive, the exposure happened 3 months ago, right? We've learned, however, that there are a number of reasons that even a single exposure can lead to deposition throughout the hair shaft. For example, some studies have shown the presence of certain synthetic cannabinoids in hair before they were even available on the drug market. So we know that the hair growth rate and the phase of growth in children is variable. So 1 centimeter may not actually correspond to 1 month. We also know that drugs can be incorporated into hair via sweat or sebum or external contamination. Sweat tends to coat the entire hair shaft when someone is sweating, and smoke can result in deposition anywhere along the length of the hair shaft. So it's relatively easy to imagine how a drug might show up in multiple segments. Damage to the hair from cosmetic treatments such as coloring, relaxing, or perming can actually lead to a loss of 50 to 80% drug concentration, but that damage can actually also result in increased uptake. There's even a concern that the process of hair testing itself may lead to incorporation of drug throughout the hair shaft. So in other words, during decontamination, in the same way a substance moves out of a strand of hair, it may also move in. These are also the reasons we can't measure the amount of hair exposure or amount of exposure to a drug from hair. So let's look at a couple of cases. Case 1 is a little girl born at 35 weeks gestation. The mother reported a history of morphine use 4 years earlier and marijuana use before the pregnancy, but denied any drug use during the pregnancy. The infant's urine at birth was negative for these substances, but a hair sample taken 3 weeks after delivery was positive for cocaine. Because neonatal hair grows during the last 3 to 4 months of pregnancy, these results were interpreted as indicative of maternal addiction and active drug use late in pregnancy. Thinking back about what we just talked about, what's the problem with this? So first, we know that a hair test can indicate systemic exposure or environmental exposure. So maybe the baby was exposed during the pregnancy or maybe after she was born in her home environment. Second, does this really indicate maternal addiction? So we know that if this was an environmental exposure, it may not even be the mother who was using. We also know that a drug can be incorporated throughout the length of hair from a single use. So it may represent repeated use or it may not. Case 2 is a 21-month-old female who was brought to her primary care doctor for increased sleepiness. When the medical provider couldn't find a clear reason for her symptoms over the course of several visits, he became concerned that the parents were using a medication in their home to make her behavior easier to manage. He eventually reported his concerns to investigators and hair testing was performed. On further history, it was determined that mother was being treated with carbamazepine, which is an anti-seizure medication with sedating properties. Hair drug testing was performed as well as segmental analysis with the results shown here. The case eventually went to court where the judge wanted to know if the numbers that you see here could have resulted from a single exposure. Now, there are several interpretations of this data that make determining how or when this child was exposed really difficult, although I'm only going to talk about a few here. The first possible interpretation and the way segmental analysis was historically interpreted is that there was ongoing exposure with drug detected in all 4 segments, with a decrease in administration in the more recent period, which is why we would see a lower level in the first centimeter of hair. However, as we talked about, segmental hair analysis is not a reliable way of determining this in children, so let's move on to the second. The second interpretation is that the child had been given the same amount over the past 4 months, but due to an increase in body weight as she grew, the same dosage resulted in lower concentrations in hair over time. Third, the results could represent sweat contamination from the mother as the girl slept with her. The older hair could have been in contact longer with the bedding, resulting in higher concentrations in the older segments. Ultimately, they were not able to conclude whether or not the child was intentionally being given carbamazepine, but the results could indicate that she was in an environment where carbamazepine was being used. However, we technically can't even say whether that was the home environment or not. Okay, so that was a lot again. I'm going to pause if there are any questions.
There's a few questions, yes. First question is, are there any implications if an agency only uses hair analysis for testing, i.e. in prosecution?
I would say largely no. I think, like I mentioned before, every test is going to have advantages and disadvantages, and so there's no test really that you can use that's going to be perfect or perfectly accepted in court. I think the important thing, whether you're using hair testing or a different type of testing, is to know kind of what the limitations of that test are, because really we have to be able to tell the court, tell jurists, what we really can say and when we can't say from a result. So no, I don't think there's really any implications in prosecution per se. I think it can make, like hair testing, for example, can make it more difficult in some cases to kind of talk about what it really means for the child. But again, I think, when I've talked to people that do use hair testing, they tend to use it in an entire evaluation. So it's one piece of a larger picture.
Great, thanks. Another question, what if the kid got bald before the test is taken?
If they got bald?
I'm assuming if they shave their head is what that means?
Oh, got it. Okay. Yeah, so I mean, that is definitely a consideration. So you essentially are wiping the head clean of, of any evidence of drug exposure. And so you do definitely see parents, for example, that they know that there's going to be a hair test who will then shave their kids' heads, which frankly is another child maltreatment issue, I think. But regardless, what I would say in those cases is that you can use other types of terminal hair for testing. The problem is, again, is that kids don't tend to have the same terminal hair than an adult was. So obviously underarm hair, pubic hair, beard hair are not things you're going to find, but you can use other types of hair. You can use other matrices, so things like fingernails, things like that, in cases where the head has been shaved.
Wonderful. Should multiple tests be normally used? As this pertains to children, are there times when using just one test, I'm assuming, makes sense, or should multiple tests be used in most situations?
Yeah, that's a good question. I think it really depends on the situation. So, for example, like at our institution, we primarily do urine testing. And blood testing is available as well, but blood testing has a very, very low yield because of the limited amount of time in which a substance is found in the blood. And so if you're going to do a blood test, you'd also want to do a urine test because the urine is going to be much more likely to catch it than not. I think kind of the same sort of thing to me goes for hair testing. So if you're going to do hair testing, if you're in an appropriate window, I think it's also a good idea to do a urine test because we know that hair testing is going to miss an exposure within 7 to 10 days after that exposure. It takes about 7 to 10 days to incorporate into the hair. And so urine testing can kind of cover that gap in cases where, for example, the child was just removed from an environment. So I'm not going to say that, every single time multiple tests should be used, but I think thinking about using it multiple times and trying to use a combination can provide better, more concrete evidence in cases.
Awesome. We're getting a lot of questions. This is good.
Oh, goodness.
So if a mother, other caregiver uses a substance, sweats, and then holds a baby or older child, their sweat can contain the substance. And if the sweat gets on the child's skin can absorb the drug. And we would still be concerned about an environmental exposure, but it is perhaps less easy to prove the source versus systemic exposure.
Okay, so I'm not exactly sure what the question is there, but I guess what I would say is that when you have a mother, for example, that is a user, so and she's sweating, there's sebum, like all the normal skin excretions on her, and she's holding a baby, what we really worry about is transfer onto hair. So we don't really have good evidence to say that when somebody holds a child and it gets on like a drug or a metabolite from mom's sweat, gets on the skin, that they absorb it to any appreciable degree, or that it becomes an ingestion. Like, for example, if, I don't know, the baby is hugging mom or something like that, and then it's on their hand and they put their hand in their mouth. So we don't really have good evidence of that. What we do have, though, is evidence that when a child is being held by a user, substances on their body, so in their sweat or sebum, can get transferred onto the kiddo's hair. Now, this would obviously be considered like an environmental exposure, but the problem is that an environmental exposure, so something just being on the hair, can incorporate in. So that's really where that confusion kind of comes in, and we can't really say, was this because they were around somebody that was smoking, or was this because they were being held by a caregiver who uses?
Thank you. What are the advantages or disadvantages of using meconium drug test or drug screening as it compares to hair testing?
Yeah, so that's a good question. I would say a couple things. I think meconium, it tends to be more like urine in the sense that it is better standardized than, for example, hair testing in young children. Having said that, though, I think that there are institutions that do hair testing on newborns. Usually you're getting results from the last trimester, whereas meconium is a little bit longer than that. It's more than 1 trimester. And you tend to have a much higher yield from meconium than you do hair, primarily because you're going to have more of the substance, right? Because every child is going to expel meconium when they're born, every healthy child, I should say. But a lot of infants have very, very little hair, and their hair is extremely thin and not really, it's very hard to gather a pencil size amount. So I think those are kind of the major differences in the test.
Great. Does Children's Wisconsin have a lab on site to complete this testing, or is it a send-out test? And how long does it take to get test results?
Yeah, that's another good question. So I would say we don't have hair testing facilities on site. We do have urine testing. So the ED drug screen that I had talked about is one that can be completed very quickly. It's usually within a matter of hours, and that's right on site. But the actual comprehensive drug panel that we actually prefer using here is a send out. And so it's billed to take about 2 days. I would say in reality it's probably closer to 5 when you factor in transport time, business days, and that sort of thing. So obviously, again, not a test that you can be used when a child is, in the emergency department, something like that. Results are going to come back later.
Okay. How concerned should we be as professionals or people in general about the impact of exposure via sweat? Thinking about case 2 that was presented, if a parent is taking a medication or substance, at what point does exposure become significantly negative or harmful to a child?
Mm-hmm. Yeah, so it's another really good question, and I think that one I'm not sure I have a great answer for, to be honest with you. So we don't really know kind of what the sub intoxication levels of drugs do to children, and this is kind of in any regard. So even for example, the kiddos that come in here and we do a urine drug test on them and they test positive for cocaine. If they're not symptomatic, we don't know what effect that really has on children. Essentially, they have a drug in their system. We may assume that there's nothing good about having that drug in their system, but we don't actually have a really good way of saying what that risk is to the child or measuring what that risk is. So I don't think there's a great answer to that. From the research that I've done on this topic, there was nothing that was published that said, a parent holding a child or a child sleeping with a parent that's exposed to sweat or sebum that contains drugs resulted in X, Y, or Z symptoms. I haven't seen anything like that, but can I say that there isn't an ill effect because of that? I don't think that I can.
And what is the second word you're saying rub off onto a child's sweat and?
Oh, sebum. So sebum is an oily substance that is excreted with sweat. It's essentially the oil glands that you have in any of your skin. The medical term for it is sebum.
Okay. Could you go over the timelines of getting the results for each test type, hair, blood, and urine, and how long each of those shows the drugs can be in the body?
Yeah, you betcha. So hair is going to be by far the longest. I would say that the general time period is going to be 7 to 10 days after exposure until 90 plus days. Obviously, that's going to vary. There are some times where a substance is going to show up in hair sooner than that, and where, depending on cosmetic treatments and things like that, it exits the hair sooner than the 90 days. Urine is about 3 days. I would say the highest yield is going to be within the first 24 hours. But then again, depending on the drug and how, kind of what the chronicity and level of exposure is, it could actually be detected up to 7 days. 3 is about the average that we quote, though. And then blood is going to be the shortest. So that is about 2 to 12 hours. I can't think of a time where a test result has shown something in blood that hasn't shown up in urine. It's such a short period of time that it's in the blood and it overlaps with urine. And so again, it's a pretty low yield test. Caveat being, if a child comes in impaired, so they're symptomatic, a blood level is a really good thing to do because urine and hair really can't give us an idea about how much a kid was exposed to. They're both kind of these reservoir matrices, something after the fact. Whereas blood, it's something active. It's affecting the body at that time. And so if you get an amount at that time, you can actually start estimating how much the child was exposed to and when.
And there's 2 more questions. Do we have time for them, Dr. Petska?
Give it a shot, we'll see.
Okay, if urine was taken for a child but not for drug testing, but another test showed drugs, what time frame is allowed for using that urine to then be used for a drug test?
Okay, so I think I understand what the question is. So, I mean, it depends how it was stored. I think that's going to be the best answer there. So, if urine is frozen, technically it can. I mean, if it's frozen low enough, it can be. I mean, a year or more. I mean, it's a long time. Most labs will only keep a specimen for about 3 days. And there's certain, so a testing facility will not accept a a sample that is older than a certain amount, depending on kind of what their stability data is. So for example, if we had urine stored and we send it for the send out, if it's been stored longer than say 30 days, they start to worry about stability. And so they may not test it because they can't guarantee their results.
Okay, and one more we'll get to. I recently had a young boy who tested positive for marijuana in his urine. Mom stated that she had just been giving him a few CBD gummies. How much CBD would be needed for this? Are there any other likely causes other than ingestion of marijuana?
Yeah, that is actually a really good question, and I don't know that I have the answer for that. That would be something to talk to the Poison Center or a toxicologist about, because they would probably have the best data on that. I would say that CBD. The problem with CBD is, even though it's legal, you can give that to people. It's not very well regulated, and so you have a lot of CBD that actually contains THC or marijuana itself, and so kids, who are receiving CBD, it's not regulated by the FDA, and so they may actually be getting marijuana without their caregiver's knowledge. So that would be something I think to check in with a local toxicologist or the Poison Control Center.
Great, thank you. And if we have any other time at the end, then we'll continue with questions. But
okay. All right, so I'm going to move a little bit quicker now, because now we're going down to the wire here. So I want to talk a little bit about interpretation. A negative hair drug test in a child does not exclude substance abuse in their caregivers. So a negative test could indicate there was no drug exposure, which is always what we hope, but it's also possible that the substance was not on the testing panel. Most hair testing companies only look for drugs of abuse in their metabolites, whereas more and more we're identifying children being inappropriately exposed to over-the-counter and/or prescription pharmaceuticals. In addition, we know that we are missing novel psychoactive substances, so synthetic drugs that are constantly being changed ever so slightly to avoid detection. The substance may also be at a level too low to be reported. So every lab has a level at which they report a positive, and if it's below that threshold, whether or not the drug is detected, it's reported as negative. Third, although hair testing has a long window of detection, it's not forever. We talked about really anything more recent than 7 to 10 days or more than 90 days can miss the exposure. Finally, a substance may not be incorporated into hair. So things like insulin or growth hormone molecules are too big to move from the capillary into the hair follicles. Interestingly, in hair analysis, it can also mean that something such as a cosmetic treatment or environmental exposure happened after the drug incorporation. For example, there is a case report that was published this year in which a 42-year-old man who used opioids chronically for pain control, so they were prescribed opioids, he had measurable morphine in his blood on autopsy, but he had negative hair testing results. So in this case, the caveat was that the man was found deceased in a pool 2 days after he was last seen alive, so the negative result was attributed to exposure to the chlorinated water. What about positive tests? So really the only interpretation that can come from a positive hair test is that the individual used or was exposed to a drug during the 3 months prior to collection. While hair drug testing can be used to detect drug use or handling in a child's environment, it cannot differentiate where, so in which environment, or when the exposure occurred, why, so the intent of the exposure, whether accidental or intentional, how much a child was exposed to, or how, the route of exposure. A positive result could indicate contact with drug smoke or the actual drug via contaminated surfaces, contact with the sweat or semen of a drug user like we talked about, or accidental or intentional ingestion of a drug. While this difficulty in interpretation has led some institutions not to utilize hair testing, others report that it is the first objective finding that can be reported in some cases of suspected child maltreatment. And in some states, an environmental exposure to a drug legally constitutes child maltreatment based on the assumption that a child may have been placed in a potentially harmful situation by caregivers. I want to talk about a few drugs in a little bit more detail. I'm going to do this kind of quickly, but basically there are 3 cannabinoids that are looked for during hair testing to establish marijuana exposure. So THC is one, it's metabolite carboxy-THC, and then more recently CBD, like was just asked about. In a 2015 study out of Germany, scientists determined that very little THC is incorporated into hair via systemic exposure, so that's by blood, and that THC and carboxy-THC, its metabolite, can both be present in the hair of non-marijuana users due to the contact of hands, sweat, sebum, or smoke of marijuana users. So we kind of knew that already, right? As a result, in 2017, though, another study was performed to look at this issue more in depth. The author looked at the results of hair testing for marijuana and its metabolites done at autopsy for children 24 months or younger who died from abusive head trauma, mechanical asphyxia, or sudden infant death syndrome. 2/3 of the children tested positive for exposure to marijuana. However, none of the concentrations met the Society for Hair Testing's criteria. Furthermore, forensic pathologists were unable to determine when or how the child was exposed. The author included 4 possible interpretations of these results, either in utero exposure, although none of the moms reported marijuana use during pregnancy, administration by caregivers to achieve sedation, close contact to marijuana users, so their hands, bedding, or dishes, or inhalation of smoke in the environment. The study concludes that there is serious risk of overinterpreting cannabis findings in hair. Something similar was done for methadone as well. In 2017, Kintz et al. Described cases of 4 children who were 16 months to 4 years of age who were exposed to methadone, 3 of which died as a result. Hair testing was performed in all 4 and found similar concentrations along the lengths of the hair. The author ultimately interpreted that this result could be consistent with repeated exposure or contamination, because one of the adverse effects of methadone intoxication is excessive sweating. And as we discussed earlier, sweating can lead to distribution of a drug along the length of hair, regardless of the number of times a child was exposed to the drug. There's also concern about bias in hair testing, so the role that hair color plays. Melanin is the pigment produced by melanocytes that gives skin and hair its color. Darker hair has more melanin and lighter hair has less. The problem is that melanin provides binding sites for certain substances such as heroin and cocaine, meaning that for any given exposure, drugs may be detected at higher concentrations in darker hair than in lighter hair. So as an example, there are reports of a 10-fold difference between concentrations of drugs in pigmented versus non-pigmented hair with the same systemic exposure. This obviously raises concerns about potential racial or ethnic bias in hair testing. This concern was initially raised in animal studies, but was again suggested in a study in 1997, in which there was significant variation in who tested positive for drug exposure, which you can see here. Although some have suggested this is due to different types of drug use in different populations, this concern was further supported by a study in 1998 by Henderson et al. Well, a 2011 study by Farst demonstrated that children living in meth homes can have drugs identified in their hair regardless of hair color. The possibility of systemically identifying more racial or ethnic minorities as drug users remains a concern. So we talked about the various limitations of hair testing. Does this mean that it shouldn't be used? I really don't think that's what I'm trying to say. I think what a better way of thinking about this is that we need to be careful about how we use it and how we interpret the results. We need to know what the limitations are so that we know what we can and can't say about a result. So for example, qualitative hair testing, determining whether or not a drug is present, has a better evidence base than quantitative drug testing, trying to interpret results based on how much or the concentrations of drugs detected in hair. What about retesting? So the results of a retest really have no bearing on the results of the initial test. If we have an initial positive result that's been confirmed, retesting provides no additional information. Positive could mean that the child is still being exposed, or it could mean that the child is still positive from the initial exposure. A negative could mean that the child is not being exposed anymore, or it could mean that the child is still being exposed, but we missed the window of detection. Unfortunately, the negative result can give people kind of a false sense of security, and the child may still be at risk. So what can you do to ensure reliable results? For one, any result, regardless of whether you're using hair or urine or blood, the test has to be confirmed to prevent the possibility of false positives. A false positive just means that a test comes back positive, but the drug is not actually present. Usually this happens because some tests look for a specific molecular structure in order to determine whether or not a substance is present. Unfortunately, there may be cross-reactivity with similar molecular structures in other substances. We have to be very cautious about acting on an unconfirmed result. A positive result for methamphetamine specifically should lead to consideration of which isomer is present, so which form of the drug is present, as the L isomer, which is one of the forms, can be found in over-the-counter nasal preparations and other prescription meds, unlike the D isomer, which can only result from exposure to 3 substances: prescription methamphetamine or Disoxin, rarely prescribed for ADHD because of its abuse potential; bensphetamine or Diedrex, which is sometimes used for obesity and metabolizes into methamphetamine; or street drugs. We also need to make sure that whatever lab testing is being performed is CLIA certified. So the lab is CLIA certified, which stands for Clinical Laboratory Improvement Amendments. Basically, this ensures high quality, standardized testing that allows various labs to get the same result. Another important consideration is education. So we really have a responsibility, medical providers in particular, to inform investigators and courts of the limitations of any test we perform and to resist the urge to provide a yes/no answer, which courts sometimes expect. The last point I want to make is that although that there's no evidence that a positive hair test has an impact on preventing future maltreatment, I would really extend that to say any drug test. We don't have a lot of evidence to say what that outcome will be for the child. We assume that identification results in improved outcomes, but that study has yet to be done. The U.S. Department of Health and Human Services recently published a set of guidelines on the use of drug testing and the results based on national best practices. Well, these were, I think, originally intended to apply to testing of parents for drugs. They also apply to drug testing in children. I have not included all the guidelines from the original publication, but wanted to highlight some of the more important ones here. First, drug testing should not be used in isolation nor replace a comprehensive assessment of the child's health, home environment, and caregiver needs. It has to be seen as part of the whole picture and be corroborated by further investigations before decisions are made. A positive drug test in a child can only be viewed as a risk factor when assessing a child's welfare. It is not necessarily indicative of parental problems or child maltreatment. So in conclusion, the opioid epidemic, legalization of marijuana, the presence of widely prescribed psychoactive substances and other factors guarantee that we're going to continue seeing drug-endangered children well into the future. As a system, we have to develop best practices regarding drug testing of children that are based on scientific evidence and prioritize the safety and well-being of children and families. In order to do this, we need to know the limitations of any test that's being performed, and drug test results have to be interpreted carefully by a medical professional in the context of these limitations, as well as the history, medical evaluation, and investigation. These are my ridiculous number of references, and I would be happy to take any last questions.
One question, is it possible to have a positive hair follicle test and negative urine and blood test?
Yes, absolutely. And I think that's kind of the finding that is most often the case, because again, the drug moves out of urine and blood much more quickly than hair. So you can get a positive hair test when blood and urine have already gone negative. And I think that's actually kind of the more typical finding.
Thank you. I'll ask you to leave the attendance slide on the screen for a couple of minutes. Attendees, if you've not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar, Medical Neglect and Child Maltreatment, presented by Dr. Ann Budzak. Thank you for being with us today.